This is a follow-up to a presentation I gave in year 1 of this echo about genetic testing. And so this is kind of, that was kind of the front end of genetic testing. Now we're going to be looking at a little bit more of the back end. And also a little bit more about the process for genetic testing. And so one of the things that I think is often most challenging and challenging to genetics professionals as well, but challenging to colleagues who aren't necessarily trained in genetics is how does the testing even happen? Like what do we do with the testing, and why do I get so many variants of uncertain significance, and what do I do with those? How do I counsel that? So those are kinds of things we're going to be talking about today. So here are my disclosures. And then the agenda, again, we're going to do an update on what interpretation of genetic testing looks like. We're also going to talk a little bit about how we use the results of genetic testing and the importance of reclassification of genetic testing. And I have a really good case. This is actually a case of mine from a couple of years ago, where it was very important for us to gain additional information so we could reclassify a variant. And I hope that everybody leaves with the idea that that genetic testing and interpreting that genetic testing is a very dynamic process. It's not static at all. We'll be followed with a couple of cases. And so one of the cases will be Dr. Stephen Eng, who is going to be discussing a very interesting patient that he and I have been working up together. And this is a case that we're very interested in the inside of the group on this as well. The second case will be done by one of my partners, Dr. Bonnie Sullivan, which is a known, but is no less interesting, and really has a lot of implication for the kinds of things that we're going to be talking about today. How do we utilize? How do we as genetics professionals or non-genetics professionals use genetic testing? So I just want to remind everybody a little bit about turnaround time for genetic testing, because it's been 4 years since we've talked about this. And there are differences, but we still have some of the same general trends. A lot of times you can get, if you're lucky, you can get relatively straightforward genetic testing back in just 2 or 3 weeks. For larger panels, it might take a little bit longer, although that time is decreasing as well. Whole exome sequencing still takes a fair bit of time, and 8 to 12 weeks is what I've been hearing most commonly. Although you can get rapid exome, and what rapid means is very different depending on where you're at. In some cases, rapid exome means very, very rapid, and you might get some actionable data within a week or two. In some cases, a rapid exome might be more thorough, but it might still take you 30 days. So, rapid doesn't always mean as rapid. And there's also still no exact delineation between what constitutes a small panel versus a large panel. The one thing I will say that's probably different, the way I practice now versus the way I practiced in 2019, is I have an ever lower threshold for forgetting the panel altogether and just going straight for whole exome sequencing. And that's certainly true in patients who are referred for non-skeletal reasons, particularly those patients who are kind of our bread and butter dysmorphology patients who may be presenting with multiple anomalies, developmental concerns, autism spectrum disorders. I think we have a lower and lower threshold for just going straight and saying, let's do whole exome sequencing, because we know the yield is there. And the time and cost, that gap between what a targeted panel and what exome would be is really narrowed, and so it probably doesn't behoove us in many of those cases to do anything differently. So we're going to talk about a little bit about the variants themselves, and so again, this is just a bit of a refresher from when I gave the first half of this talk in 2019. But when we do a genetic test and we get a result back, if the result is identified, it's going to be in one of the 5 following categories. It's going to be considered pathogenic, likely pathogenic, a variant of uncertain significance, likely benign, or benign. Now, it is generally considered appropriate to not include likely benign and benign in a report. It is often very confusing. There are still a couple of labs that oddly enough still will report out likely benign and benign variants in kind of a secondary table. I don't prefer that. Again, I think it's confusing, and especially because we know that these are not actionable. Variant of uncertain significance is a variant of uncertain significance, and we'll kind of unpack what that is. And we really treat pathogenic and likely pathogenic as being actionable variants. And so in practice, we will treat a likely pathogenic very similarly to a pathogenic in terms of what we do. Some of the counseling might be subtly different because the overall level of evidence to get to likely pathogenic is somewhat less than it is to get to pathogenic. When I have, it is not at all uncommon for a likely pathogenic variant to be eventually reinterpreted as pathogenic. That often doesn't change what we do to manage the patient, but it is good that they continue to amass that sort of evidence to move that back and forth. So that we treat those as actionable. And this is a really small, this is a big table with small fonts. And so I actually am going to unpack this entire table for everybody so everybody can see how we go through it in genetics. And this is more our molecular colleagues than those of us who are clinical genetics or genetic counselors. But even though we are not necessarily the people who are signing out the test, we still very much use these criteria when we're thinking about a variant and understanding what it's going to take for a variant to be reinterpreted, if that is something that would be important to the patient. So we're going to go by this by each individual category, so people understand kind of how we look at these variants and what they mean. And one of the things that before I go into this that should be noted is when you have a criterion that supports being a benign variant, you generally will be in just the categories of supporting and strong. And there is also a standalone benign that we'll get to in just a moment. For pathogenic, we have more categories. An individual criterion could be supporting, it could be moderate, it could be strong, or it could be very strong. And the combination of those criteria are what's going to eventually decide what the initial classification of that variant will be. So we use a lot of different pieces of information, different types of information when we're trying to form this opinion. And one of the things we use is population testing. Is the variant present in the population? Because if a variant is rare, that doesn't mean that it's automatically disease-causing or pathogenic, but it makes us a little more suspicious. So when we see a variant that is the allele frequency is too high, we sometimes will see allele frequencies that are higher than what we think the totality of the disease prevalence is. That is much less likely to be a pathogenic variant. And so that is a strong criterion for benign behavior. Again, strong does not mean it's a standalone. There is a standalone if you have an allele frequency of greater than 5%. And this is in any sort of general continental population data set. And this has to be at least 2,000 observed alleles. And it has to be found in a gene without a gene or variant-specific modification. So there are rare cases in which a very, very specific findings in a few genes might still be relevant with an allele frequency of greater than 5%. But in the vast majority of cases, that is not true, and this can be considered a standalone benign. But you have to be very careful about what that population looks like. So when we have our population norms or kind of population allele frequencies, we will do this on the entirety of a human population, but we will also substratify out by continent or in some cases by certain ethnicity. And continental populations are important because a lot of times that will encompass a lot more human variation and will be far more helpful. We have historically done an extraordinarily poor job in genetics of representing the entirety of human variation. We are getting better about that. Our job is by no means done, but we are getting better about that. So that is our standalone benign. So what about pathogenic? Well, so for pathogenic, a moderate criterion is if it's absent from population controls. Again, rare means rare, and it's interesting, but it doesn't mean that it's automatically a pathogenic variant just because it's rare. A stronger criterion would be if you actually have an enrichment of an allele in affected samples versus controls. We often don't have that information. Once in a while we do, but we often don't have that information. And so that's not a criterion that I see commonly used. Then the second type of evidence we use is what we call computational and predictive. And so there are several benign and pathogenic supporting criteria. So for benign, we have computational methods of suggesting whether a variant is likely to be disruptive or not. And these are, these are computer-based, many of them are free to use for anybody. And if they don't agree with one another, and they often don't agree with one another, then that's not a criterion either way. But if they point in the same direction, that can be a supporting criteria. If they all suggest no impact, so that is more supportive of benign behavior. If they support that it's disruptive, that is supportive of a pathogenic behavior. But again, that's only a supporting criterion. What we find is that there are some of these tools that are very pessimistic and will much more frequently suggest a variant is disruptive. Some of them are more optimistic and are much more likely to suggest no impact. And so we take, when they don't do that, we pay a little more attention. So for benign supporting criteria, we also see missense variant in a gene where only truncating variants found to be disease causing. So the majority, and I'm going to have a counterexample of this in my case, but the majority of variants that we have trouble with that end up being a variant of uncertain significance are missense variants. They substitute one amino acid for a different amino acid. And in many cases, it's very difficult for us to predict what the likely outcome of that amino acid substitution is. But if you have a missense variant and the only things that have been described as being disease-causing are truncating variants, which are often nonsense variants, frame shift variants, certain splice site variants, if that's the only thing found to be disease-causing, we might not be so concerned about a missense variant. And so that would be a supporting case for benign behavior. Another supporting case would be a silent variant. So this is not, it is a change that does not change the amino acid. Oftentimes it's in that third nucleotide in the codon, or we call the wobble base. That is typically, those are often not disease causing unless they are near an intron exon junction, what we call the splice site, then those can still be disease causing. But if it's not predicted to impact splicing, then we think that those are more likely to be benign. And then another supporting criterion is what we call in-frame indels. So these are insertions and deletions that are in frame. They don't change the reading frame, and they are in repetitive regions of the gene. And repetitive regions of the gene, generally speaking, that also don't have known function. Because there are some repetitive regions that still have function, but there are a lot of them that don't. So basically, you're changing the length in some way of a repetitive region that has no known function, but you're not doing so in a way that's going to cause a frame shift, because those can be a problem. So additional pathogenic variants or pathogenic criteria can include moderate, which means the variant changes protein length, and we'll see that in our case here in a bit. Changing the protein length, again, not always a problem, but it's still a concern for us. And so it's considered a moderate criterion. And then another moderate criterion is the variant causing the change is in the same, not residue as a known pathogenic or likely pathogenic. What does that mean? Well, it may mean that if you have a native residue in that location that is a glycine, and a glycine to serine substitution has been described many times, and you don't have a glycine to serine substitution, you have a glycine to alanine substitution. Well, it's the same residue, it's just not the same change. But we would still consider that to be a moderate criterion to support pathogenic behavior, because what that tells us is that is an important residue. And so changing that amino acid for a different one, even if it's not the one that's been seen before, is of concern. Not enough to be interpreted that way by itself, but still important. And then a strong criterion is the same amino acid change as a known pathogenic or likely pathogenic. Well, again, it might be a different change to the wobble base, and so they might both be that glycine to serine substitutions, but one of them might be they might be different nucleotides that are changed. That's a strong criterion, because again, we know that amino acid change is important, and so that's a strong criterion. So those are going to be very likely to be pathogenic. And then very strong is a null variant where loss of function is a known disease mechanism. And so, if we know that loss of function is a problem and you have a loss of function, even if it's not something that's been seen before, that's still going to be deeply concerning. And then what about functional data? So we don't have functional data a lot of the time, but if you have studies that have a functional component and they show no deleterious effect, that's a strong criterion for benign behavior. For pathogenic, if you have a supporting criteria is a missense variant in a gene with a low rate of benign missense variation. So this is kind of the opposite of what we talked about a little bit ago. So these are genes where we know missense variants are a problem, and we don't see a lot of just noise. We don't see a lot of just kind of random variation that doesn't seem to cause problems. And there are tools like Nomad that we can all go to learn some of that information. And so that can be really important. And then also a moderate criterion is a variant hotspot or important functional domain without benign variation. This is actually kind of hard to use. And so how do you define what important functional domain is? And so this gets a little fuzzy around the edges and kind of introduces the idea that there is still a little bit of subjectivity to interpreting genetic testing. What we have now, the framework we have now is better than it used to be. But it's still by no means perfect. And so there is a little subjectivity in what you decide, what is an important functional domain? And then a strong criterion is well-established studies show deleterious effect. It's really nice to have functional studies, and these can be, in vitro studies. These could be potentially with a model organism. If you're seeing recapitulation of a phenotype in a model organism, that can be super helpful. We don't have that information a lot of the time, but if we can get it, it's really, really important. And then segregation data. So basically, does the genetic change follow the phenotype in the family? So if there are multiple members of a family that are affected, and you don't find the variant, you find the variant in some members of the family and not others in a way that seems random, that's a strong indicator that that variant is not causing the phenotype. However, on the opposite, if you have the segregation of the variant with the disease in the family, if it always follows the phenotype in the family, it's much more likely to be pathogenic. How strong that is depends on how many family members are there. If it's just a 2 or 3, maybe that's supporting criteria. But if it's a bunch of family members, if we're seeing multiple generations of family where the variant follows the phenotype, that could be as much as a strong criterion. And so family data is actually very important. Likewise, if it's not family, if it's de novo, if it's a new change in that person, that's also important. So it's a moderate criteria if you presume de novo without parental confirmation. Now, that doesn't mean that you just don't test the parents. It just means that you haven't taken that other step to confirm that the parents are really the parents. That's what they mean by that. And then strong is if you confirm parents, which we really should always do, and we know that it is in fact a de novo variant. Though that's going to always be concerning. Again, not standalone, but very concerning. And then also allelic data. So if you have a variant that is in trans with a dominant variant that you know is pathogenic. So one single genetic change causes this, and you've already found that genetic change. If you have a different change on the opposite allele, that's much less likely to be disease causing. So in a recessive condition, or even if it's observed in cis in kind of on the same allele with a pathogenic variant, maybe they're actually maybe they're being co-inherited as an allele or as a haplotype. We don't always know that information, but basically, is there a different explanation? Is there a better explanation for the disease than the variant that's in question? And then for pathogenic or recessive disorders in which you need to have both genetic copies knocked out, it's observed in trans with a known pathogenic variant. So you have a known pathogenic variant on one allele, and you have this variant that you're trying to figure out on the other allele. That's a moderate criterion for pathogenic behavior in that instance. And then what about other data? Well, these are actually really difficult here. There is a supporting criterion for both benign and pathogenic that says reputable source reports as either non-disease causing or disease causing. That's tough. And I find that labs, I don't think are really using that so much anymore. The reason is because it was our understanding of variation as it is today is relatively new. I'll back up a little bit. So when I was a baby geneticist, straight out of fellowship, we were just getting next generation sequencing online. And so we were, for the first time ever, we were able to do panel testing. And so we were getting data from multiple genes at the same time. And we were so excited about it that we went out and we created all of these amazing panels of 80 genes, 40 genes, whatever, a phenotype. And we had no idea what kind of variation was out there. And we had no formal mechanism for interpreting these guidelines, because this is 2012, 2013. The guidelines that I'm describing to you now didn't come out until 2015. And so we had several years where it was kind of the Wild West. And so you had all sorts of different variants that were interpreted in very different ways. Labs did not have standardization. One lab may have interpreted something as benign. One lab may have interpreted as likely pathogenic. Who's right? We don't know. And so it turned out to be sort of the Wild West, and it was a very difficult time. And so within that period of time, there was also a ton of literature that was generated. And there was literature that was generated before that. And that literature was generated at a time where we didn't have this framework. And so I'm not sure that any of those sources are truly reputable. And, I'm thinking, like, I have a couple of papers from 2012, 2013 that I wrote that I don't think are reputable now anymore, but for that reason. We interpreted things the best we could, but it turned out, we had a better method. And so, I wouldn't trust myself from that long ago. And so it's really difficult to use this in a practical way where you still think the source is reputable. And then another supporting criteria is a variance found in a case where an alternate diagnosis was identified. So sometimes you'll find these variants that are just sort of along for the ride, and you're less likely to think that there's an additional phenotype, although dual diagnosis does still happen, and we can't ignore that. One of the other criterion for pathogenic, and we'll talk about this with the case as well, is the phenotype is highly specific for the gene. That is very abusable, and we'll see in a little bit why. So putting it all together, so I've talked about the individual criteria. How do we call something pathogenic or likely pathogenic? So if we can either have a very strong plus one strong, two moderate, one supporting, two supporting. You can have two strong criterion. You can have one strong and a combination of moderate or supporting. For likely pathogenic, it's a little less, but you still have to have a very strong and a moderate, or a strong and a couple of moderates, or some kind of combination of moderate and supporting. And this is one of the things that's really hard is when you have a missense variant that you've never seen before. A lot of times, even if you're getting the most criterion you're likely to only get two moderate and two supporting, even if it looks like a really bad actor. And so if you can't get all of those, then it's going to be a VUS. So it's actually really hard if it's a new missense variant that something we haven't seen before. It's not in any of the databases. It's actually really challenging to get that to likely pathogenic. So so those are the combinations there. What about benign? So for benign, either have one standalone or two strong. For likely benign, one strong, one supporting, or two or more supporting. Keep in mind these things in mind, because every other combination of criterion, or if there are conflicting interpretations, those are going to be a variant of uncertain significance. And so I think that understanding a little more about how we do that, and how conservative these guidelines really are, and they're pretty conservative. There is a wide swath in the middle between about 89% sure that this is benign versus 89% sure that this is pathogenic, that we have to call a variant of uncertain significance, because the data needed to move it to one of the more definitive categorizations is significant, to get a lot of data to that. So that's why the burden is there. And they can be anxiety producing for clinicians and patients. And if possible, we like to get information on assortment of a variant within the family, We also like to, again, see how a variant behaves functionally. A lot of times we can't do that. So when I review a VUS, I retrace the guidelines that the laboratory used to interpret. And again, these are the American College of Medical Genetics and the Association for Molecular Pathology guidelines. And we look for that trend. Is a trend towards pathogenic? Is it benign? Or does it lack a trend entirely? Is it just kind of right in the middle? Well, that helps. It helps when we do that. So even if I can't get a VUS one way or the other, I will still give the patient my best information. And so I will use, my two of my partners are online and they've heard me use this language before, is if there's just nothing distinctive about the variant, even if I can't call it something different, I will often refer to it as a bland variant. It doesn't mean that it couldn't eventually be interpreted as pathogenic or likely pathogenic, but there's nothing distinctive about it, and so it's bland. Most bland variants, if they're reinterpreted, end up being reinterpreted as likely benign, but it takes a while a lot of the time. Or if there is something distinctive about it, I might refer to it as a concerning variant. I can't call it likely pathogenic. I can't call it pathogenic. It may still not be actionable. There may not be enough information for that, but I may still be concerned about it enough that I want to keep track of the patient and keep track of the variant, because sometimes those do get reinterpreted as likely pathogenic. So we want to look for that trend, but that's actually very important. If we can integrate family history, that's really helpful too. And, does the variant assort with the disease, or is it a de novo variant? That can be very helpful. And if we can integrate clinical history and phenotype, that's really what we would like to do. So how do we disclose that information? So ideally, we would like to reclassify the variants, but let's just say that's not possible. Again, we want to level with the patients, because everyone does have a different tolerance for ambiguity. Some people handle it really well. Some people don't like it at all. Sometimes it is helpful to explain the process. I don't do it in quite as nauseating detail as I just did, but I do give people kind of a window into the idea that interpretation of genetic testing is a process and is dynamic. And so, follow-up is helpful as variants are often reclassified. And that is really important to know. When we're doing kind of dysmorphology, because all of our patients are one-offs, that a lot of times that reclassification happens pretty slowly. But one of the other things that I do clinically is cancer genetics. And so in cancer genetics, it's not one-offs. It's not the single dysmorphology patients. It's population-based testing. You're doing thousands of tests for cancer indications, and a lot of times you're doing the same core set of genes, and so a lot of data is being generated. And so in cancer genetics, it's actually very common for a variant of uncertain significance to be reclassified. If I looked in my email account at KU, I guarantee you I would probably have 25 reclassification notices in there. And I would bet that all of them are from variants of uncertain significance to likely benign. And so we know on a population level that is the most common reinterpretation of a VUS. The problem is if it's a single variant, you don't know that. You can only speak in probability, you can only speak in statistics, and oftentimes that's not really reassuring to the patient. So we just have to kind of cop to having that sort of ambiguity. So one of the things we can do over time is we can actually ask for testing to be reinterpreted. And this is particularly true for patients who are having whole exome or whole genome sequencing. A lot of times, if we don't have an answer or don't have a firm diagnosis, we'll ask that to be reanalyzed. We'll ask that testing to be reanalyzed. And when do we do that? Well, sometimes even just if there's been enough time that's passed. It may not necessarily be a triggering event with a patient. It may just be enough time's passed, because we get a lot of information over time. And that sufficient time seems to be somewhere between about 1 and 2 years is enough time for that to be meaningful. Or if we have a patient phenotype that evolves, even though we're getting a lot of data, a lot of raw data from the whole exome or whole genome sequencing, that data has to still be married to the phenotype, because you can't interpret in a vacuum. You must have phenotype there to really be able to accurately evaluate that variant of uncertain significance. And if that patient phenotype evolves, you have additional search terms that you can use, to gain additional information or be able to interpret this a little bit better. So sometimes that's a good trigger to reanalyze. And then sometimes just at the request of the patient or caregiver, sometimes they just ask to be reinterpreted. And within reason, if it's been 3 months, tell them why it's probably not a great idea to reinterpret for 3 months, because it still costs money and all that kind of stuff. But if it's been a couple of years and a patient asks me to have their testing reinterpreted, I'll usually help them out with that. And in some cases, we have found some answers on a reinterpretation. So how do we counsel? So, and again, when we're doing a results review on a diagnosis that's been established, we review we go kind of through a certain set of stages. And a lot of times this discussion may be done by a clinical geneticist, oftentimes working in tandem with one of our genetic counselor colleagues. In many cases, for this sorts of results review, the genetic counselor is doing the heavy lift. And in some cases, genetic counselor is doing these sorts of results review on their own. And we as the clinical geneticists kind of function in a kind of supportive and consultative role. But what I see us doing is reorienting them to the type of testing that was done, what type of variant was found, what gene was it found in, did it confirm a clinical diagnosis, and also what caused this to happen. And this is really important and shouldn't be skipped, because one of the things that parents want to know, if you find a diagnosis, especially if it's a new change in the child, is, did I do anything to make this happen? And the answer to that is always going to be no. There's nothing you did or didn't do, and there's nothing you could have done to prevent this, because I find that parents will often retain a lot of guilt if they have a child that has a genetic diagnosis. And we can say that you shouldn't have guilt and that you shouldn't have guilt, but we also know that I think all of us as parents would probably bear some amount of guilt. But it's important for the families to be supported in that way and to understand that this is not something that they could have prevented. So diagnosis is established. So clinical features. So what features fit? What features does a child maybe not have yet that they could develop? You want to give anticipatory guidance, talk about things like penetrance. We have some conditions that we see in the clinic that have high penetrance, like Osteogenesis Imperfecta. There are others that have incomplete penetrance, like hypophosphatasia. Incidence is important, and then management is important. What do we do now? What do we need to do? What do we need to do on an annual basis? Are there therapies that are available? Is there educational accommodations that need to happen, either for cognitive reasons or because of physical limitations? And these are things like 504s and IEPs. We want to talk about this sort of stuff. Are there devices that could be helpful? Do they need mobility devices? Not necessarily for bone disorders so much, but for a lot of our other patients, do they need communication support? So this is really important. And then what is the mode of inheritance? And is there familial testing that needs to happen? And then Mendelian genetics, everybody's a little bit of both of their parents. So, and then talking about psychosocial issues is important. So what is the social situation that the patient is in? What fears do the patient and caregivers have? Again, what guilt do they bear because of this? Is there grieving that needs to occur as a result of the diagnosis? Oftentimes there is. And that's something and this is where again, our genetic counselor colleagues really excel, is providing that sort of counseling for them to be able to address issues of grief and self-esteem, coping strategies, searching for meaning, and then understanding what the defense mechanisms patients might be employing, and using those as ways to better counsel them. And then what resources and support are there? There's oftentimes very good patient-friendly material on a condition. A lot of times this exists through things like Genetics Home Reference. NORD has some pretty good stuff. A lot of times patient advocacy groups themselves have really good stuff. The OIF and Softbones both have veritable libraries with a lot of really excellent information. And then sometimes people that maybe have higher health literacy want a little more technical literature. Sometimes that's appropriate to give them and walk them through that. And then things like support group information and, if appropriate, other family contacts, because there may be another family that's going through something similar that would be open to that contact, where you can make those sort of introductions. So I want to end this with a case, and then we'll move on to my colleagues who have a couple of great cases. So we're just going to call this case 1, and this is changing interpretation with new information. And this is, and in case 1, we use family history. So this is a case that from a few years ago. Infant was born with a suspected lethal skeletal dysplasia, and we evaluated them. And when we evaluated them based on the appearance of the radiograph and the appearance of the child, we suspected hypochondrogenesis. And so, skeletal dysplasia panel was obtained, and a variant was found in COL2A1. So COL2A1 is a gene that we would not be surprised if we indeed have a diagnosis of hypochondrogenesis. And it was a duplication. It was an in-frame duplication. So in this case, there were 2 of those of the collagen, procollagen triple helices that were duplicated. So I think a lot of us know that there's the triple helix in collagens of glycine, proline, proline. And in this case, there were 2 of those repeats that were duplicated. So it did not change the reading frame, but it did change the length of the protein. Aha. So when we interpreted this, or when the lab interpreted this, and we kind of went back through it, we had only a couple of criteria. So we had 2 moderate criteria. One, it's absent from controls, so it's rare. Okay, that's a moderate. It's also the protein length changes as a result from the in-frame insertion in this case. Okay, so it's another moderate. That's not enough though. And so I said, well, I think this patient's phenotype is really specific for this disease. And so I think we should add what we call PP4. So this is just a supporting criterion. So I think we should add that. Well, okay, we still have 2 moderates and a supporting. That's still a variant of uncertain significance. So we're no better off with that. So what do? Couldn't we just add PM6? Couldn't we just say we think this is de novo without confirming maternity or paternity? No, we can't assume this. We have to actually go look. And so what we did, and so parents were tested, they didn't have the variant, and parental identity confirmed. So we know that these parents are the parents, and we know they didn't have the variant. So now we get to integrate PS2. So this is a strong criteria saying de novo with confirmation of parental identity in a patient with a disease and no family history. Now we have 1 strong, 2 moderate, and 1 supporting. That's likely pathogenic. And so we are then able to make that. So that's one way that we were able to very quickly integrate family history and do so in a way that we could change the interpretation. And it was important because this is an actionable variant, and we were able to give helpful information to this family. And we can abuse the phenotype, by the way. So, if a patient phenotype is highly specific for disease with a single etiology, we have to be very careful about how we do this. We need to make sure that the clinical sensitivity is high. Most patients will test positive for pathogenic variant. It's a well-defined syndrome. Family history is consistent with the mode of inheritance. We can really abuse this. So here's an example where I think this is okay to use. So we've got a 31-year-old female, recent diagnosis of sarcoma and history of adrenocortical carcinoma. Lots of family history of breast cancer, sarcoma, brain tumors. Okay, so this is, clinically, this is Lee-Fraumeni syndrome, and that's pretty specific. We get a cancer panel. Yep, there's a variant in TP53. I think you can use PP4 for that. I think you can use the phenotype to support that. Alternately, you got a 5-year-old male, recent diagnosis of an autism spectrum disorder, seems non-syndromic, not really a lot of too much family history. And we did find a concerning missense variant in a gene called SHANK2 that we know is associated with autism. Well, that's not enough. That's not specific enough. We can't use the phenotype in those there. So that would be abuse of this criteria. And so we would not want to do that. So you have to be very specific when you use the phenotype in molecular interpretation. So I'm going to end here and turn it over to my colleagues. But what I hope to leave you with as a result of this is that genetic testing is a dynamic process. It's not just a static result. Family and functional data is critical for making an accurate molecular diagnosis. And also yield is never 100%. I don't think genetic testing is a particularly good test to use for ruling things out. You can make diagnoses, but because there are people with variant negative disease, as we're going to see with Dr. Ng's case, we don't necessarily want to use it to rule it out. We want to use it really for its diagnostic purposes.